Stem cells, exosomes, and regenerative medicine, an overpriced fad or the future of medicine. In this episode, we walk through the landscape of regenerative medicine. So, if you've heard of terms like stem cells and exosomes and PRP and prolotherapy and X cells and V cells and follistatin gene therapy, this episode we explore them all. We also discuss other biohacks and more affordable ways to get similar benefits or to increase your own stem cell pools without expensive procedures. Our guest this week also specializes in cartilage regeneration and the world of anti aging. He is Dr. Jeff Gross. Known as the stem cell whisperer, Dr. Gross has worked at the National Institute of Health, the NIH, and had opportunities to study MIT, Johns Hopkins, and eventually chose Berkeley, where he worked under Nobel laureates. He trained at top trauma centers, and his landmark research on brain tissue has been cited nearly 500 times. Perhaps most relevantly, though, he continues to treat patients in neurosurgery, focusing on non-surgical approaches and regenerative medicine, often providing second opinions and consulting internationally. If you're very involved in the world of biohacking and specifically the events and summits, you've surely seen his name as he's often a presenter at most of the big conferences. You can find his work online at ReCELLebrate.com, ReCELLebrate, where he offers a wide range of services. And for listeners of this podcast, just mention my name, Nick Urban, to receive a free 30-minute consultation. You can find everything we discuss in the show notes for this episode, which will be at mindbodypeak.com/175. If you have any questions or comments, we'd love to hear from you. So go ahead and reach out on Instagram at mindbodypeakperformance or simply tag me and Dr. Gross, and we'll get back to you. All right. Sit back, relax, and I hope you enjoy this episode with Dr. Jeff Gross. Dr. Gross, welcome to the podcast.
Thank you. It's a pleasure to be here. Thanks so much.
This is going to be an exciting one because I have never covered in depth the topics of regenerative medicine and cartilage repair and a lot of different things that are in your wheelhouse on the show before.
Well, I'm happy to be the first to help explain things and educate you and your audience and spread good information, good science, and the good word.
Let's start off today with the unusual non-negotiables you've done for your health, your performance, and your bioharmony. And it's a couple hours earlier over there for you. I know you're in, I believe, Nevada. So if your list isn't as comprehensive as a typical biohacker's, that's a-okay.
Well, I do a lot of things, but I think the non-negotiables would be time-restricted feeding. Some people call that intermittent fasting, but I don't think we're designed to eat during the dark phase. So I don't like to call it fasting because we should. Fasting seems like on purpose we're not eating. This is intermittent feeding. So I definitely am a very big, somewhere between 16 and 18 hour non-feeder, depending on the day. I have it down to a routine so that if I fudge from 16 to 18 hours or vice versa, I don't get too worked up about it. The second thing would be my supplementation. I make sure I get my anti-inflammatory supplements and other things we don't get in our diet. And I take a long list of things, but I don't start people on a long list of things when they meet with me because it's too overwhelming. But I do modify from time to time my daily, that's my midday snack. So I do believe we don't get these things in our diet. And if we were eating of the earth, with organic, really diverse fruits and vegetables and meats and things, we wouldn't need all that. But unfortunately, we have a very watered down food source and affected water supply and all whatever else is in our air. So we're fighting inflammation at a higher rate. And I think we see that, if I can go off topic a little bit, we see that in younger people having, hormone deficiencies and earlier inflammatory problems and so many people with inflammatory type diseases, autoimmune things. We're seeing this across the population. So you got to fight inflammation, and the younger you start, the better. And that can be through lifestyle, through supplements. So the supplements are non-negotiable. They're easy to do. Once you get it, it's part of routine. Um, and the investment, because you does cost some money to buy these, is that always preventing, right? Preventative medicine comes first. And then third would be exercise. And I'm guilty of not always getting that done because of my crazy schedule. But I think the one take all pill to fix everything that you could do would be move. And there are some hacks and strategies on how to get the most out of strength training. And it doesn't have to be a 2-hour gym trip every time, that kind of thing. But
To double click into your supplement stack a little bit, you mentioned the anti-inflammatory nature of the things that you take. Is there a reason that you're focusing specifically on that? And I'd assume that the substances you're using are not just anti-inflammatories, they have other benefits as well.
sure, of course. And we throw around this phrase anti-inflammatory, or if you don't hyphenate it, maybe a word anti-inflammatory. But um, it's a kind of a general concept that we age because we are slowly oxidizing. We are biologically rusting. If you think about an old car sitting out in the garage, and it's just hasn't been used, and it's the old chrome is rusting. Back when they had chrome on cars, um, we are biologically rusting, and the faster you rust and the more you rust, the quicker you age. And age is really this accumulation of chronic inflammatory damage in the cells, the tissues, and that inflammation leads to degeneration. And of course, we'll talk about the opposite of degeneration is regeneration, and how you get the opposite of inflammation is anti-inflammation, right? So that's the overarching thing, is we really want to slow the degradative degenerative process, the inflammatory process. And the earlier you start and the more you do, the slower you age, the slower you will develop the risk of disease formation, particularly diseases of inflammation. And frankly, most diseases, except maybe some genetic ones, although there's some overlap, are an inflammatory disease of an inflammatory nature. Osteoarthritis, diabetes type 2, Alzheimer's disease has an inflammatory component. All the autoimmune diseases have an inflammatory component. Cardiovascular accumulation, hardening of the arteries has an inflammatory component of the plaques. I mean, all of these things can be slowed / reversed / prevented. So back into your double click in the maze, things I start people on, the 5 first things. Every anti-aging doctor will have a little different stack, and you can compare all these fun opinions and get to make your own choices. But I'm a big believer in omega-3 supplementation for anti-inflammation, out competing some of the bad fats and things. Fish oil, good fish oil is classic. Now we have different types of omega-3s, the fatty 15s and others. Mix and match, change it up. But I believe an adult should have about 3 grams minimum a day. And you look at the blue zones where people live healthier longer. We talk about longevity, but really it's healthy longevity and health span. Like Okinawa, their omega-3 indices, meaning the index of the amount of omega-3 in their body that have accumulated over time from probably a lot of the seafood they have access to in Okinawa. That's probably one of the reasons, not the only reason, but one of the reasons they do so well. So you can have a little bit of Okinawan in you by taking the right omega-3 supplementation, but significant amounts. Some people take even higher than we have other people on higher amounts to get their omega-3 indices up. So that index is a lab test. I'm a very big fan of good probiotics. I think that, when I went to medical school, decades ago, we were not taught about the microbiome. We were not taught about the gut. We were not taught about supplements. And I had to go back and learn that. And I am such a big fan of the anti-inflammatory nature of our invited / uninvited guests. Some of them are invited, some of them are uninvited, that live in our gut and other places in our body. I'm focusing on the gut, but we have biomes everywhere, right? Skin and other places.
Mouth.
So, but the gut microbiome, when we're kids, I grew up in the Midwest, and, before there were really screens, and, mom would send us out to play, right? And we would play sports in the grass and roll around and wrestle and do what boys do and get dirty and get soil on our fingers and, probably got some in our mouth. And we had this diverse, healthy, young, of the earth microbiome growing, and we were healthy and we could heal and we didn't have problems. Well, kids today are sitting inside in front of a screen. They're not doing that. And certainly adults at a desk job, and, to some extent mine is, and maybe yours is. So we have to supplement and replace that microbiome, either that or go roll around in the mud, every morning or grounding. Third, I like proper restorative sleep. And the two things, among others, that we use for that at night would be a really good multimodal magnesium, because so many cell processes require magnesium. And if you don't take a good supplement, by the way, it does help with restorative sleep during the night. We'll get to that. But if you don't take a good supplement, you'd have to eat, 10 to 12 servings of leafy green vegetables a day. And some people do. But even the vegetables we have now the nutrients are bleached out, watered down. What we're getting is not the free range stuff that of 200 years ago when you grow your own vegetables. So magnesium. And at night, I am a big believer in melatonin, even if you go to sleep fine. Classically, people use melatonin to help them sleep, which it can. But it actually is the dark phase hormone, dark phase being no sun out. In the morning, cortisol is released from the adrenal glands once the sun hits our eyes, once the retina in our eyes. And we release this stress hormone so we can get things done. We can hunt, we can fish, we can, take care of the day and all the things we need to do. But our cells are busy inflaming during that time. And they need equal opportunity to repair and restore, repair DNA, fight oxidation. That happens mostly during the dark phase. And if we don't give ourselves proper downtime through restorative sleep, they won't get there. So the opposite sort of opposing hormone of cortisol is melatonin. Sadly, after puberty, we don't make hardly as much. You get deeper sleep, restorative sleep, your cells heal better. And we know this if you measure HRV. Anybody that wears an Oura ring or a Whoop band or now Apple Watch has it and others, your heart rate variability, if you don't get proper sleep, your body has physiologic detriment the next day.
Yeah. But I want to really
Sorry.
quickly touch on your routine. You mentioned focusing on the anti-inflammatory stack and upregulating that system in the morning. It sounded like there's a concept called redox, which, as I understand it, is the balance between anti-inflammatory or oxidation and reduction. It's like the two sides of the seesaw. And you also mentioned one of your daily habits is exercise. And back in, I don't even know how long ago, one of the leading theories behind the cause of aging was simply a mismatch of too much oxidation, not enough reduction, too much inflammation, et cetera, et cetera. And then they realized that that's an incomplete picture. And there's forms of healthy inflammation that result from certain lifestyle things like the hormetic stressors, such as exercise. Are you at all concerned that by consuming anti-inflammatories after a workout, as a number of papers have shown, that you'll blunt some of the beneficial adaptive or hormetic effects of exercise?
No, and we know this from HRV tracking. There's some wonderful data, community data on this. The Whoop band statisticians are probably the best at this. You're right about the hormetic stresses to build resilience, right? You've got exercise, you got hot sauna, you got cold plunges, you've got fasting, real fasting. These build resilience to acute inflammation, right? Healing is acute inflammation. You cut yourself, you want that acute inflammation. What we don't want is chronic leaky inflammation. And these type of supplements are really fighting against the chronic mediators of inflammation, not necessarily the acute mediators. So people who track HRV will tell you that if you overwork and do too, you can overdo it with exercise, right? There's too much too. So they will tell you that, you find your sweet spot with the exercise. And I don't have any fear that we're goofing around with the seesaw by taking the anti-inflammatories. Now, is there an ideal time before and after a workout, or when you should take them? That I don't know, and I don't know. That would be a very difficult study to do, but worth looking at. So it's a great concept.
I think the other missing layer there is your age. For example, when I was younger, like a teenager, I could do double days, triple days of like weightlifting, like heavy resistance training, and then football practice or rugby training, and then hit another session and I'd recover fine. My HRV would not tank like it would. But as I get older, I can no longer sustain that. And what I've seen is that the inflammatory response, it's no longer as efficient as it was previously. It spikes and then drops. And then as you get older, it kind of just ramps up and doesn't decline as it should. And so I see a stronger case that as you're aging, it makes more and more sense to have these types of things because you're also going like if there is a blunting of the hormetic beneficial effect of exercise, it's probably pretty negligible unless you're an Olympic athlete or someone really who needs every last little morsel, then perhaps it's not the good choice, but for everyone else, it makes sense.
That's a very keen observation. So when we look at, just as an analogy, HRV or heart rate variability, we want the healthy heart is the one that responds and adapts quickly to demand and to relaxation. Well, you're almost asking that here. You're creating I never thought of this before. You're kind of creating an inflammatory variability. We want an
Mm.
adaptable inflammation system that can turn on and turn off. The
Yeah.
problem is with a chronic accumulated inflammation, it doesn't turn off as well, and it gets leaky. So we almost want to learn how to improve our inflammation system variability. And I'm coining that here with you, so we can patent that later. We'll give it a thing. Maybe it'll be a measure on your phone, and we can look at the the cell mediators of that. But this bridges over into regenerative medicine. And I know you didn't necessarily. If you meant for that, you're brilliant. You're brilliant anyway. But our stem cell reserve is less functional, and less voluminous, less functional as we accumulate chronic inflammation, and vice versa. As we accumulate chronic inflammation, that system is less effective. So we can't suppress the chronic inflammation, and the acute then doesn't fully turn off because we want the acute. And you think about this: if you've ever seen a toddler playing on the sidewalk, scrapes his knee, has an abrasion, cries, mom cleans it up, puts some Bactina on it, or whatever, puts a bandage on it, kisses it, and sends him on his way. And then 3 days later in the bathtub, the band-aid falls off, but the abrasion's not only a scab, it's a mature scab, it's almost healed. But you look at like a 70-year-old person who bumps their elbow, has a bruise for 3 weeks. So why can't that 70-year-old who healed so quickly as a 3-year-old, the same genes, heal as rapidly? What's happened to that body? And that's depleted functionality and number of stem cells. So regenerative activity, regeneration. So it comes from that.
I think it is time to step back and define some of these terms because there's going to be a lot of things that we're going to discuss. And unless someone is heavily steeped in this field, they're not going to have any idea and they'll get lost very quickly, as I am when I hear about all these new types of regenerative procedures that are just being tossed around in everyday like biohacker conversations.
Where do you want to start? I'll let you drive.
Look, okay, I'll lay out some of them. We can revisit them after I list them. First, stem cells, then PRP, prolotherapy, X cells, V cells, stem cell derived exosomes, exosome therapy, and certain gene therapies, because I think those fit into the bucket of regenerative medicine also.
I think they sort of overlap with regenerative medicine. I'm not doing any gene therapies. We can define it, but I don't think we're going to get into it here today. I'm not. Stem cell 101, we'll start there. So stem cells, when you were a fertilized egg in your mother's womb, for the first, you're a single cell, then two cells, then four, then you're an embryo. You're made of cells that have amazing potency and power to become a small human fetus, right? And those cells are called stem cells. Now, these are embryonic stem cells. They are extremely powerful, and they are the most powerful stem cells. Why do we call them stem cells? Because all cells stem from them, right? This is the mother of all cells, right? The single cell embryo makes two cells, et cetera, and that just goes on and on. And as that embryo develops into a fetus, which is sort of this, animal shape looking, thing in the womb before it looks, humanoid, those stem cells start to differentiate into specific types of cells, right? Some cells are going to become the heart, the liver, the arm, the whatever, the brain. And there are three main layers, three main types of cells in the embryo once they sort of divide out into those cells. And they're called the outside, the middle, and the inner layers. Okay, of the when you look at an embryo, it forms into these layers, and that's ectoderm for outside, mesoderm for the middle, and endoderm for the internal. Most of the body's tissues come from the mesoderm. It forms most of the organs, except the brain, the teeth, and a few other things, which is ectoderm. There are a few other things that are ectoderm and endoderm. Some of the glands are mixed, but most of the tissues of the body are mesodermal. And I'm saying that now because when you look at a fully, a fetus ready to become a baby to be delivered, um, and we talk about, harvesting stem cells from the umbilical cord and things like that, we're really taking mostly these mesoderm cells, and mesoderm it becomes the middle tissues, or what's we called also mesenchyme. And you hear mesenchymal stem cells or mesenchymal stromal cells or MSCs. Those are these multipotent cells that reside in a human after delivery. So a baby helps the baby grow and develop, and then helps us heal and regenerate our tissues. So, skin is constantly renewed through this process. Liver cells, hair follicles, things like this are constantly renewed. And if you get injured or you have to heal it, the immune system calls upon these cells. They're all over the body, but mainly in the bone marrow more than fat. And these are all mesodermal. Now, when we talk about stem cells for therapeutic purposes, we're talking about these mesenchymal stromal cells. They are multipotent. They can't go backwards and form a new human. They can't regrow a limb. You have to go back in the lineage of stem cells from multipotent to pluripotent. And we can do that. There's a reversal process. That's not currently clinically available in the US outside of a few studies. And those are called induced pluripotent stem cells. And they can be induced backwards even to an embryonic state. These are very powerful and not fully controlled and understood. So we are not using them, although there's a lot of excitement and promise in those induced, reversed cells back towards a more embryonic state. But what we're using clinically throughout the world, generally speaking, are these MSCs, and they're multipotent. They can become almost any tissue in the body that's of mesoderm origin. And we help use them as a strategy to help people fix things and repair things and help the body heal and regenerate like they were a much younger person. We're taking that strategy we've learned about and simply reapplying this natural biologic approach. So generally speaking, that's regenerative medicine.
So it sounds like there'd be very little value to someone who is younger because they already have a naturally greater pool of those stem cells.
Generally, that's true. Now, there are some specific applications. For example, autism and chronic infections, people with immune syndromes and hyperinflammatory syndromes that can benefit from regenerative approaches, even the young people. And we have seen some of that. But most of the work is in people whose regenerative apparatus is not doing what it used to do or was designed to do when they were much younger.
So then it seems to me that a good first starting place here for everyone would be to figure out the factors that are rapidly depleting your stem cell pool and to address those before going on to a potentially very expensive procedure, because you might be wasting them if you're rapidly depleting all your stem cells when you could first try addressing that naturally and then layer it on top, and it should be more effective.
I agree with that. In fact, when people do, seek our advice and are looking for a regenerative approach to something, we make sure that they have lined up everything and stacked the deck in their own favor so that any type of treatment they do try will have the best chance of success. So this means, lifestyle factors, diet, restorative sleep, epigenetics in all forms, supplementation, hormone optimization, peptides, everything else has been optimized extensively because sometimes that alone will suppress the inflammatory problem adequately and slow the the process.
Are there any top causes or factors that you see that are not the basics, like sleeping more or moving more or eating what are clean foods, that kind of stuff?
Yeah, I think we're killing ourselves with our diet. So we are in a world of processed foods. They're full of chemicals that are supposed to make them have longer shelf lives and not melt if they're cold or vice versa. All these fillers and binders and things, and the nutritive value of the grown food isn't there, right? It's got fertilizers in it, and even the word organic at the store means that it's 95% organic. So the what's in the 5%? So, and if you look at countries that have perhaps not as industrialized societies, they don't have these types of inflammatory problems, right? So now we have this balance here in the first world, and that's that we have longevity that is kind of peaking around, the average is about 79 to 82 years old. And that's all comers, that's smokers. And if you look at the life tables, the government life table, that's everybody, you know. So that means half the people will live longer, and the people who are healthier longer are doing things for their health and wellness longer in their lives, will live to 100, 120. We're going to have increasing populations that do that, even if the average doesn't move.
Well, you also just tied this back into what we were talking about at the beginning, because if you have a very high inflammatory burden, it sounds like you'll be depleting your stem cells more than you would be if you weren't.
Agreed. All cells get gunky and rusted. Remember, we talked about biological rusting, and all cells have a diminished capacity. We call it cellular metabolism, but their ability to do their job, make the right proteins. And if they get really bad, they become zombie cells, right? They
Yeah.
become these senescent cells that take up space and resources, blood flow, nutrients, but they don't give back to the community of cells. So, in a lot of the senolytic medications to support longevity, are designed to help remove zombie cells. Like a lot of them advertise that.
Yeah.
So if you can target your zombie cells and recycle them through different types of cell lysis, cell death, for those, or we call apoptosis is the medical term, right? So you can kill off those cells, then you can recycle their resources. And we're looking, and that's called autophagy, where the cells eat themselves and then recycle their components back into healthy cells. And now we're looking at that for not just cells, but mitochondria. We're looking at mitophagy, and so many supplements and activities you do support mitophagy, which is a super healthy thing. And a lot of the hormetic activities you mentioned earlier to build resilience, you see that correlate with good mitophagy and good autophagy.
Yeah, I've written articles on senolytic therapies, and a lot of these things you've discussed. I have some of their products. They don't make much difference to me as far as I'm aware, because I'm not in like the target demographic for them, but it's interesting to learn about and to try nonetheless. Are there any other therapeutics that you see working really well in conjunction with stem cells to either, I guess, mainly to amplify the effects and or like help get more from the same expensive procedure?
Yeah, I'm a big fan of peptides and even some of the bioregulators, depending on
Mhm.
the individual person's needs. I don't think we're going to get too deep into that, so we want to stay on the stem cell topic. And you've had other good um, guests on who've talked about peptides, but that you think about peptides like they're something new. They're not. We have many peptides in our body at any time. Let's list a few: insulin, uh, endorphins, some of the neurotransmitters, and peptides all around us. Melatonin is a peptide. If anyone's using semaglutide or tirzepatide for weight loss or other or anti-aging purposes and anti-inflammatory purposes, those are peptides. So we're now learning more and more about these small fragment peptides that we've had all along. We just didn't know enough about them as cell signaling and as gene influencing. So they don't change your genes, but they influence which genes are called upon, because we want to call upon the healthy, youthful, regenerative, restorative, anti-inflammatory genes. We don't want the other, cell. You talk about C cells. Cells kind of have two metabolisms. Only like we as a body have two metabolisms. We're either anabolic, so we're, we're storing glucose and building, or we're catabolic, we're burning. Well, cells are similar. They're either fighting against the rust, the inflammatory nature of our world, whether it's food, water, air, electromagnetic fields, all these stress, even neurostress. Our cells are making those and calling for the immune system. That's that chronic leaky inflammation. Or they are in optimal mode, which is anti-inflammatory, and they make different set of proteins. So we want to, do everything we can to keep our cells in a more anti-inflammatory, rust fighting mode.
Okay, so we've talked quite a bit about stem cells so far. I'd assume that's the most popular like regenerative medicine therapy, is it?
In the world, yes. In my office, no. And hopefully we'll move next. I think we should move backwards, if you don't mind, first
Yeah.
and talk about like PRP and prolotherapy, because when we talk about regenerative biologics that can be used in a therapeutic way.
Yeah, I guess before we go on to those, I want to make sure that we clarify like what are the pros and cons of each of these, because it's one thing to like understand to get all the terminology. It's another to understand, okay, this is how and why I would choose this versus that.
Well, I think if I can define them and then the comparatives might be more
Sure.
instructive, if that's all right. Okay. So the very lowest level almost of regenerative medicine is PRP, platelet rich plasma. And this is generally taken from your own blood. You draw a number of vials of blood and you spin it in a tabletop centrifuge in the office. And the blood separates between the red part, which is the red blood cells, and the plasma, which is sort of the watery juice of the cells that has different things in it, proteins, hormones, things like that. But in the middle, there's a small little, area, and it's kind of got some platelets, which are a type of cell, and it's got some growth factors. And it turns out that stuff is really rich in a lot of the anti-inflammatory cell mediators
Mhm.
that are also the regenerative cell mediators. So growth factors and things like that suppress inflammation.
Mhm.
So if you can suppress inflammation, you can then rebuild. So you can actually, pipette out or suction out that middle layer and take it from a few tubes, put it together, and re-inject it in an area of need, like tennis elbow, which is classic, or a knee strain or something like that. So you're concentrating the body's own regenerative capacity in one area that the body simply wasn't able to do that efficiently for some reason. So that can help. Usually you go for 3 sessions spread over a number of weeks. And that's very common now. And if I can even go backwards down the maze for a second, this is all for educational purposes, and none of the regenerative therapies we're going to talk about are approved for marketing claims, including PRP. But ironically, health insurers have figured out that 3 sessions of PRP is a lot less expensive than some type of surgery. So they are now paying some of them for PRP treatments.
Wow.
Yes. And this is actually not new. This has been going on. So just for definition of terms, another type of treatment is called prolotherapy.
Mhm.
Prolotherapy is taking either a sugar or salt substance and in causing a local inflammation. So it's a sclerosing agent, or usually you do it for lax ligaments. You want to tighten things up, causing a heel and scar tissue reaction. So that sort of overlaps with regenerative medicine. That's been around for a long time. That's not new. And you can get a series of those. I don't know that some health insurance is paid for it or not. So that's prolotherapy. And then we've talked about PRP. And by the way, PRP can be used for the face, for skin rejuvenation. It's called a vampire facial. It can help with thinning hair. And then the next level up will be stem cells. And we should say that stem cells, which I defined earlier, can come from two sources. It can come from your own body, just like PRP, where you usually harvest it from the fat or from the bone marrow. And that can be done in an office setting or what have you. Some people choose to bank their own fat-derived stem cells, and that can be done just like you can bank your child's umbilical cord now. And you can pay to have that banked at a lab, and then when you need cells, they're available. There's some evidence that doing that at a younger age is is good because when you get older, you want some of the younger derived cells that haven't been exposed to chronic inflammation. So that might behoove you to do something at a younger age, just put it aside. And that can be done very simply. The other source of stem cells, sort of almost the easier source, is from perinatal donation. So whether it's from, your own child or a relative's child, or these days off the shelf, there are plenty of places that do perinatal donation. So these are planned C-sections here in the United States. They're usually from people who, or the labs I use anyway, are from people that have not had the COVID vaccine. And that wasn't necessarily a political statement, although it could be. It's because we just don't know the long-term effect, and we don't want that variable in the mix. So these are from non-vaxxed donors. They're screened early. They're healthy women, and at the time of a planned C-section, they're donating. They do not get paid. They're donating their amniotic fluid, umbilical cord, things like that. And it gets sent to, ironically, an FDA certified lab that follows all the protocols, is inspected, and has the right cleanliness standards, what have you, sterility. And they're tested, right? They're cultured. They make sure they don't have any virus, any Epstein-Barr, any CMV, any HIV, anything, right? And then those are concentrated and made available to us as end users. So we just buy them from the labs. And that's a very simple, efficient source. I've never seen any kind of rejection since this is not your own material. Unlike a child who has sadly leukemia and has to undergo a bone marrow, replacement procedure. They give them chemotherapy to kill their bone marrow, and then they have to have a matched donor because they're repopulating their entire immune system. That's different. Stem cells don't have a lot of the cell surface markers that identify them as being from an individual. So it's more theoretical. I haven't seen any rejections there. So then we define, I'm going to say the sort of the last or the more recent and latest version of regenerative medicine comes from what are called stem cell derived exosomes. And that's the thrust of most of my practice now. I find these quite efficient. If you look at a stem cell delivery, if I had you come over and I gave you intravenous IV stem cells, whether we got them from yourself or from a fetus, they'd be used up and gone in 10 to 14 days. And however, the benefits would last months, if not longer. And some of the benefits during the regenerative phase, depending on what we're doing for you, you get to keep forever. So how could that be? If the stem cells are gone, how come the benefit lasting? Well, it turns out the stem cells aren't doing all the work. The stem cells are making cell signaling particles called exosomes, which are taken up by your own cells, and your own cells are doing the work. So we figured out that you could skip the stem cells, which are delivering the exosomes, and just concentrate the exosomes and give them to you. Now, exosomes are much smaller than cells. Cells are measured in diameter by microns, which is 10 to the minus 6 meters. Well, exosomes are about 1/1000th that size and measured in diameters in nanometers, 10 to the minus 9. So they can cross the blood-brain barrier. They can cross other tissues. They penetrate the body and tissues better than stem cells do. Stem cells are too big to get into if you give them IV, to get into your brain. So if you want to deal with the nervous system, exosomes may be easier delivery. Also, stem cells intravenous, the heart and lungs take up quite a bit of them. Their cells are sticky, they bind. The heart gets a good dose, which is great for the heart. If you're recovering from a heart attack or something, a stem cell IV might be great. And then, because the vein goes right to the heart, then to the lungs, then back to the heart before it gets to the body. So the body doesn't get the type of direct dose from intravenous stem cells as it does from exosomes. Exosomes are more fluid and they just go everywhere. Exosomes are small they bubble out from the cell. They do not have hardly any markers, so they're even less of a chance of rejection. It's not even seen ever, a chance of rejection from a stem cell derived exosome. By the way, all cells make exosomes. When we say exosome here, we're talking about stem cell derived exosomes. And there are people who you can take your own blood and your own stem cells and create your own exosomes, but it's a very laborious and expensive process. It's a lot more efficient cost-wise to do stem cell-derived exosomes from a perinatal donor, because amniotic fluid is abundant. It can be concentrated and filtered, and it also comes with certain growth factors and anti-inflammatory cytokines and mediators that make it, for sometimes less than half the cost of the stem cells. So a lot of people are worried about the cost of regenerative procedures. It's come way down because of the exosomes. So now let's compare. Cost-wise, exosomes are almost as low as PRP. PRP usually runs $5, $6, $7, $800 per session times 3. Exosomes, you're usually one session, and when you add up those 3 PRP sessions, you're starting to get around the cost of an exosome session.
Is exosome just one session?
Generally, yes, depending on what we're doing. Exosomes, I think, penetrate tissues better. They're easier to handle. I store them here in my office in a minus 30°C freezer. I have a separate minus 80°C freezer for stem cells because we do a little bit of both, but really most of my work is exosomes these days. So easier to handle. They come shipped overnight to me on dry ice, so they're nice and cold. So when we deliver them to someone, they go from the womb to ice to the lab. Lab takes a little bit, tests it, to me on ice. And then when we thaw them in our hands to give them to someone, they're basically from the womb to ice to them. So they're fresh, frozen, as if they're getting. And you think about a pregnant woman, if I can divert for a second. A pregnant woman usually has wonderful glowing skin. The hair is growing robustly. The nails are growing. They're usually in a decent mood. They generally don't have a lot of aches or pains, except maybe low back pain from carrying the womb. So why are pregnant women so youthful? Because they're getting a dose of exosomes through the placenta every day. I'm not saying that PRP is wrong, prolotherapy is wrong, stem cells are wrong. They all have places. We've used these different things. But I think you get the best bang for your buck and result from the exosome.
And these are all injections, right?
There are some topical exosome preparations and stem cell preparations and growth factor preparations for some skin. But really, the real work of regenerative skin is done in the cells underneath the epidermis. So we see our best results if we're looking for skin rejuvenation in micro-injecting the exosomes like a vampire facial with exosomes. Same with thinning hair follicles or that kind of thing. So in the cosmetic group. But we can do many other things. So we can do, most of my work is either IV or structural work in cartilage regeneration. So, we take people who are arthritis, osteoarthritis, chondromalacia, or what their doctor will call bone on bone often, who are being offered or may have had a past arthroscopic surgery. Maybe they're told they're going to need a joint replacement. Those are our ideal patients. We can help those people generally, give them a chance to help them tap back into the factory that made their joint in the first place, turn that factory back on, help them and heal and enhance their cartilage. And we have some wonderful MRIs before and after knee examples where we've shown cartilage restoration by height in the knee and improvement in how people are doing clinically as well.
Wow. And this is with stem cell derived exosomes also.
Right. It's with, we follow the best practices, and everything we do is based on really good literature somewhere. So in the US, we're behind. The research had been suppressed for so long, and the funding for that research is suppressed. So most of the research we follow either comes out of Asia or Europe. So we're following a French protocol that clearly demonstrated. Their last study a few years ago was a 15-year follow-up of injecting. Now, they didn't have exosomes. They've only been around 6 years. They were injecting stem cells into the knees of people who were told they need knee replacement. So they were having knee problems, trouble walking, pain scores, that kind of thing. And they said, wait, before you do this knee replacement surgery, which is a big deal, would you like to join our stem cell study? So these doctors at the University of Paris East took half the patients, injected in the joint, in the cartilage area, between the bones of the femur, the upper leg, and the tibial plateau, the lower leg. And then the other half of the patients got injected in the bone edges subchondral bone edges just adjacent. And it was crystal clear by 15 years that the 80 some percent of those patients were still doing great, did not need that knee replacement they were once offered if they had the bone injection, where only 20 some percent of the joint injected were still doing great. So it was clear that stimulating the cartilage forming cells that live in the bone, in the old growth plates of the bone edges, that made that cartilage in the first place, called the chondrocytes, was the way to helping those joints long standing. So it's a one and done procedure. I'm using exosomes instead of stem cells because, again, I think exosomes are doing the work probably more efficiently and at half the cost, and we're getting at least the same outcomes, if not better. So whether you do stem cells or exosomes, and some doctors still do PRP into the bone edge, but a lot of clinics still do the joint injections. Now, the joint injections do help people, but they won't last as long. So that's why I recommend the bone injection. Now, bone injection sounds painful. We do it under sedation at a local injection facility, but see, I'm a big fan of this. It's called intraosseous or in the bone exosome injections. By the way, the knee cartilage, and I use the knee as an example because we have so many knees, but we do spine, we do other joints as well. The cartilage doesn't have a lot of cells. So when you inject stem cells or exosomes into the cartilage, those mediators have to penetrate back through the bone edge to do their work. There's not a lot going on in the cartilage. The cartilage is like a biological rubber gasket. And it's like hair. Hair is made by a follicle cell in your scalp. Cartilage is made by a chondrocyte cell in your bone. Other guests you've had have spoken to osteoarthritis in the body as being a metabolic disease, and it is. It's inflammatory degeneration of those cells. Well, we seek to reignite those cells and stop the inflammation, turn back on that healing capacity, that production, basically putting in a new factory order for some new cartilage.
I might have missed it. Did you say what are the downsides, if any, of exosomes versus stem cells or PRP or any of the other alternatives?
Exosomes are better cost-wise. They are easier to handle and deliver. They penetrate the tissues better. They do as well, if not potentially better than some of these other things. And I don't think there is a downside.
The whole world of exosomes, whether it's stem cell derived or from other cells, I find extremely interesting. I'm sure it'll be like a future frontier of medicine because it really explains a lot. And I read a couple of books where they mentioned exosomes, and I'm like, why isn't this more common knowledge? This seems like it should be integrated into our current understanding of human health, and I'm sure it will be in the coming years and hopefully not decades, but probably then.
Well, I think you're completely right. It is coming. And it'll come faster. You see biotech companies and big pharma is getting their hands in it, and that'll really move it. Of course, they want to monetize it. So, and I teased you before we went on about, there are things coming, right? So what we're using now are these generic stem cell derived exosomes. And we do them IV, we do them, like I said, for the structural parts of the body. We do them for many other things. We do it for a sexual function. We have men and women, P shots and O shots. We do dry eye syndrome. We've done glands in the eyelid. We don't do the eye. The eyelid is where the party is. We have some cosmetic things, lots of IVs for, anti-aging biohacking. People do it preventatively. And although a joint procedure might just be a one and done, I do the IV myself 4 times a year. And some people do it every year. Some people do it every other year, just depending on your appetite and what you're trying to get out of it. I have a sweet little old lady who has osteoarthritis, aches and pains everywhere. So we're not going to inject all her joints, right? But she'll do an IV, and it lasts her a good 2 years before her pain comes back. So see you in 2 years. We have people with cognitive enhancement. I have an attorney who comes in before a big trial and gets an IV just to sharpen his brain, so quick on his feet. We have things like that. I have some high-end athletes that do it before a big race or for recovery purposes. You do see a boost in HRV after an exosome IV without changing anything else, without changing sleep or diet or anything. But what's coming here is we've got some designer exosomes coming, and it's actually very big in Asia right now. But there are different types of immune cells in our body that fight cancer, constantly circulating through us, removing wonky cells like accidental cancer cells. Well, there are exosomes that those cells make that are highly selectively able to kill cancer cells. So we're looking at that as potential augmentative therapy for people with both circulating and solid tumors. And there are also now mitochondrial enhanced exosomes. So you look at people who are declining muscle mass, frail syndromes, older, almost, nursing home populations that are there because you've got to maintain your muscle mass and your bone density for longevity, right? So it might, having these mitochondrial stuffed exosomes might help their cells have newer mitochondria and more mitochondria, which correlates with reduced biological age and healthy longevity, as well as helping people with mitochondrial diseases. So these are coming. There are others, and also think about mitochondria for weight loss. If you have a lot of fat, that last 10 pounds you can't lose, or whatever, or maybe more, that's white fat. If you inject white fat with exosomes that are chock full of mitochondria, white fat becomes brown fat, and brown fat is easier to burn, right? That's the stuff you start exercising comes right off. So if we can convert white fat to brown fat with some injections, boom, we've got a new angle on weight loss or body contouring. There's a cosmetic side of it. But you think about exosomes in our world, we've had them all along. We just didn't notice. Most cultures have, if you're sick, your grandmother makes you some kind of chicken broth or chicken soup, right? That's chicken stock, and chicken soup is full of the exosomes from the bone marrow of the chicken stock. You look at also healthy biohacking foods, bone broth, and colostrum, and bone marrow as a delicacy. These are all high in exosomes, and exosomes are also in plants, and they're highly preserved. A lot of the little peptides that are in exosomes that the cells make. Yes, peptides. You're hearing it, peptides again, are naturally occurring forms of a lot of the peptides we use therapeutically. And you also see heat shock proteins, the healthy anti-inflammatory heat shock proteins that you release when you go into a hot sauna are found in some of the plant and fruit derived exosomes. So eating plants and fruits and vegetables is not just for the phytonutrients and the fiber and the probiotic and the prebiotic, but you are getting this epigenetic influence from the exosomes within.
This morning, I was just reading Joel Green's book, The Way, and he's going through a bunch of different foods in it, and he's talking about how they not only have a bunch of fascinating bioactive substances, but also peptides and bioregulators. And I previously thought it was just the organ meats, like you would eat, say, heart, and you get the bioregulators and peptides that would help your own heart, doctrine signatures kind of thing. But then I also realized it's a lot of other plant and like fruit and vegetable, and even I think some grains had those as well.
Yeah, I mean, it's amazing that you look back historically at our food sources going back ancestrally, and really what we're getting is a genetic influence, an epigenetic influence that is truly from some of these little peptides and things that are in those food substances, not just the nutritive value.
One thing I'd be remiss not to ask you about is if you're consuming one of these foods, say bone broth, and you're getting some of the exosomes and the microRNA and all that kind of stuff that's naturally occurring within it, that has to pass through your digestive system to some degree. Maybe the peptides are small enough that they emerge unscathed from through the other end of your stomach and they go in straight into your bloodstream and circulation. How does that compare to a subcutaneous or IV when it's administered directly into like different bodily fluids and tissues?
It's a dosing difference or a bioavailability difference, right? If you inject something right into your bloodstream, your body has it available like right then and there everywhere. Whereas if you ingest it, it goes through like your GI tract, has to be absorbed. That means not all of it gets absorbed, and it has to get into the capillary and into your bloodstream, and you just don't get as much that way. You'd have to eat a lot of bone broth every day for years and years to get the kind of effect maybe as one IV.
Okay, and so there's no safety concerns, like, by bypassing the body's, like, natural systems, you're not gonna be experiencing greater side effects. It doesn't sound like it.
Well, interesting. The only side effect that we notice is with IV exosomes is in the minority of people, and mostly people who have significant inflammatory burden, like an autoimmune condition, like Lyme's disease, like long COVID. Their cells have stored up and are ready to release the immune system mediators called cytokines. And if you remember during COVID, the sickest people in the ICU had cytokine storm. They were severely inflamed, right? They got all kinds of fluid in their lungs and their heart wasn't functioning right. And um, if your body is busy fighting inflammation, it's making those proteins. Remember, your cell is in that fighting inflammation mode, and it has vacuoles and endosomes, meaning these little bubbles in the cell, full of these things ready to release. When we give uh, the anti-inflammatory stem cell derived exosomes IV, and we ask these cells to flip into anti-inflammatory mode, it has to purge out all these cytokines. So people have a day or two sometimes of a flu-like syndrome. They don't have the flu, but they have the aches and pains because of all the inflammation from those cytokines that are being released into the bloodstream as if there's something going on, but there's not. And those have to clear out of the system. So people can have for a day or two this flu-like syndrome as their factories are flipping from wartime to peacetime.
Yeah, that was the context in which I learned about exosomes to begin with. It's like if it's how your body communicates in a way with the environment and takes information and, like, removes certain components of the cell that shouldn't be there, not necessarily the cell, but, like, things that shouldn't be inside the cell get taken out and vice versa. It's a way of, like, rapid adaptation. And so if you're sick and people around you sick, there could be an exosome component. So to me, it seems that this would strengthen the argument for doing the healthy lifestyle practices ahead of time before the procedure, because this might be affected more so than, say, a stem cell procedure or a PRP procedure or something like that. Maybe, maybe not.
No, as a preventative, this is smart. You know, uh, Doing this to suppress inflammation, slow the biological aging process. Can't slow the calendar, but slow the biological aging process, and maintain the immune system at its highest level is so smart.
Okay, and then I'm not sure if you're aware of these. A while back, a couple years ago, I first heard of V cells, and more recently, I've heard of X cells. Are you familiar with those?
A little bit. It's not something I'm doing in my clinic at this time. These are activated cells, and what's being done is, usually cells are taken out of the body, or the blood is taken out of the body. They're activated in some way, whether it's ozone or certain types of laser light, and they're re-injected, and it stimulates the stem cell activity in different ways. I'm not the expert in V cells. I'm not doing V cells. We have a great experience with stem cell derived exosomes, and we're achieving the results that people desire. So I haven't branched out in the cell arena too far. Plus, my main projects are, besides working in the office to give advice every day, is to and treat people, are these designer exosomes. So I'm academically involved, and we will be having those available at some level, whether it's a research study or what have you. Some of these ones we may be able to help with cancer and other things we're very excited about.
So if someone's interested in getting started with this, say they just had a surgery or they're going into a surgery or they have joint pain, what are the things that they should know? Because as you've mentioned throughout this interview, the landscape is a bit tricky to navigate, especially with the, like, legal status of certain things and the jurisdictions and medical tourism. How would you recommend exploring this world?
Yeah, let's cover that because there's so many myths. So briefly, there's an organization as part of our government. It's called the FDA, and they have planted a flag in saying that they regulate regenerative biologics, which is the overarching term for stem cells and exosomes and PRP and all those things, B cells, X cells, everything. They have not yet approved marketing claims. That's their job, marketing claims. They have not yet approved marketing claims for any of these things. So I cannot say to an individual that I can treat or cure a disease or condition. Well, as a doctor and a surgeon for so many, decades, I've never been able to guarantee I can fix anything. But I give everyone full informed consent. So it's not illegal to do these things. It is non-compliant for a doctor to make or a company to make marketing claims. That's it. What you and your doctor decide you do between your doctor-patient relationship is sacred, and it's just just our there are certain words that we cannot say, and I go through that. We're transparent about it. We're not shy about it. We have consent forms that say all that. So most people that come see me or get with me on a Zoom, because most of our patients actually don't live here in Las Vegas, they know about that, and they're okay with it. And most of the work we follow, the best practices, best protocols, have been developed in Europe or Asia or both, and are based on scientific publications in those areas. Sometimes we extrapolate, we take something they did with stem cells, we might do it with exosomes, but we're not getting different results. A lot of people travel to Mexico, Panama, other
Yeah.
places to have stem cells. Joe Rogan sends people, the mixed martial arts fighters, down to Tijuana. You could go there as well. They have tourism packages. You don't have to leave the country. Now they can advertise more freely. We cannot advertise stem cells, biohacking, regenerative medicine, anti-aging, or anything like that on Google or Facebook. They have something going on the back end, with the government. They won't let us do that. So most of the ads you will see, they'll be on Instagram. But what you can see that though is a lot of the websites from the places out of this country can say whatever they want. They don't have the FDA restriction.
But can they perform different procedures that you're unable to here in the US?
Probably. I mean, I'm not sure there's anything we're unable to perform. There might be things we're unwilling to perform. For example, we're not doing, these induced pluripotent stem cells, the stem cells that work backwards along the evolutionary chain towards the embryo. We're not doing those. There are places you can probably go and get those outside of the country, things like that.
So that would be one reason people would go outside the country if they want to do these more experimental things that sound really cool and promising, but there's obviously less research on them. And even if you were able to, perhaps you wouldn't because they're so much newer.
I'm just not ready for that. It's just not available to me, and I can't obtain the product, and I'm not going to get it from some questionable source, right? So you asked earlier about gene therapy. You have to leave this country for gene therapy. What's popular now is the follistatin gene. The chief anti-agers are taking, right. It's like $25,000 that lasts for 2 years. You have to go out of the country for that. So it could be quite powerful. I don't know enough yet, because I'm not going to focus my time and energies on something that I can't make available to people yet.
And for anyone tuning in who's curious about that, you can Google myostatin knockout and then any animal like myostatin knockout horse or rat or something. You can see the potential of using something like follistatin to reduce myostatin levels. It's pretty entertaining. I'm not sure I would be first in line to get that done, even though it seems to be popular today, because I think there's a lot more to work out with that technology in general, such as like off-target effects. But it's an interesting avenue nonetheless, one that I'll leave to other people to explore.
So listen, gene therapy is great. If you can change your genome and you have a genetic disease like sickle cell anemia, fantastic. You got to fix that. But when you're doing it to enhance, and it could have downstream effects, like you said, or off-target effects, that's scary. When you start modifying it's like going into your computer and changing a few words of code, thinking you're enhancing it, but then your computer doesn't boot.
Yeah, and if you don't know what you're doing, going into your computer and changing just a single letter, a single character can completely crash the computer if you're modifying the kernel or something like that. So I think there's not enough risk awareness around some of these things. And like you said, for certain conditions, it can be like literally life-saving, life-changing. But for some of like the aesthetic and other uses, TBD.
Agreed. It's great stuff. It's great research. We need to keep pushing it. We're going to get there.
Well, Dr. Jeff, you mentioned that most of your clients do not work with you in person in Nevada. How do they go about connecting with you and or working with you remotely? And what are you able to offer remotely?
Yeah, thanks for asking. So my practice name where we do regenerative medicine is called ReCELLebrate because we're celebrating the renewal of your cells. ReCellebrate. And that's how you find us. Our website is ReCELLebrate.com. Our Instagram is at ReCELLebrate. Our Facebook, LinkedIn, so just type in ReCELLebrate, you'll find us somewhere. And there are ways just to reach out and say, hey, I'd like to talk. If you mention you've heard us on Nick's Mind Body Peak Performance podcast, I'm happy to do a 30-minute pro bono, conversation, consultation. You fill out a quick form about yourself. We get on a Zoom, or if you want to send me some records or images ahead of time, especially if you've got, joint problems, spine problems. That's I'm probably one of the few centers in the country doing the interosseous, the bone treatments. I'll show you some befores and afters, and I'll knock your socks off. And then we get you all tuned up. If there's other things we need to adjust ahead of time, we do that. And then only if you're a candidate would we invite you to come to Las Vegas, make a weekend of it. Do it maybe a treatment on a Friday if it's a joint, and there's no downtime, so you can be up and walk the strip here in Las Vegas on Saturday, providing you don't come in August when it's so hot.
Yes. Very nice. And I don't think we covered this, but if someone has any of those things that you've mentioned, say they're either about to go into a surgery or they went into a surgery or they just have pain, like how do they navigate that? Like where would they find you ideally along their journey, and where can you and these procedures still make the biggest impact?
Well, I mean, the earlier we get in front of someone, we can educate that person, even if they're not ready for what we have. And it might be through other biohacking. It might be peptides. It might be, structured exercise, certain types of weight bearing exercise. It might be hormone optimization. It might be, pentosan polysulfate. It might be, all kinds of things. So the more you have more options, the earlier you get in front of us. We do have a lot of people that had like an arthroscopy surgery, like when they were playing sports in their teens or 20s or 30s, and now they're starting to have that accelerated degeneration of pain, and they're less active. They're not getting off the couch because it hurts too much. Those are ideal. The bone, when your doctor says at some point you're going to need a knee replacement, that's the person we want to get in front of, because we can try and help that person help heal that knee and stop, and then maybe reverse in many cases that degeneration into regeneration.
Yeah, I was thinking if I had, like, say, torn a meniscus or ACL or something nasty, would I want to come to you and attempt this before? I'm guessing not before attempting like a reconstruction. I guess that would have to happen first. But like, under what circumstances? Say I'm like ready for a knee replacement or a hip replacement or something. Where do you fit into that? Like, where would I get the best results? Obviously, it'd be nice to have that in advance. Say it is happening, or this procedure has to happen, or maybe not even it has to happen, but it might happen if nothing else.
We do catch people early and address tears. If the tear is catching and your knee locks, the regenerative medicine is probably not going to fix that. So sometimes we do recommend that people get that trimmed surgically. And then if there is an augmentative add-on regenerative to help them heal, it would be right after that. I just saw someone who had was a pretty bad injury, and they had a fracture of the bone below the knee, the tibial plateau. And we did some regenerative to help heal faster and restore the knee, because if those cells don't heal right in that knee, the cartilage will degenerate. As others say, this is a metabolic disease. If those cells can't metabolically function, they're not going to make support and make cartilage. So the earlier the better. We can at least be available and give advice, even if they still do need a surgery. The earlier the better. If you are, and I've had patients absolutely bone on bone, what's called grade 4, and we've been able to help them. So we catch people at the end too. Takes a little longer with them, and it's a little slower process. But
So if it was a more major injury, like say like a tear, I could go to you before anything else before deciding on something more potentially complicated and then see how that progresses. And I'm guessing with all these things, whether it's post surgery or pre operation, the time is of the essence. And the earlier I worked on it and saw you, the better.
I think the earlier the better. Even if we just meet and we look at your MRI studies and we really dig in as to the root cause of what's going on now with acute injury and what's going to happen if you don't have surgery, what's going to happen if you do have surgery. And then maybe it's something we say, okay, do what you need to do surgically. Let's meet back in 6 or 12 months and see where we are. And if you're content, then we're on standby. If and you we give you advice, peptides and other things to heal. And if you're not content, then we reevaluate because the surgeon might say, well, I did what I could, and you're just going to need a knee replacement someday. That's really where our best jump in is. We take those people and we do things that are not yet available to mainstream orthopedics. So, but some doctors are getting retrained in this, and that's what I had to do. I had to go back and retrain because we were not taught regenerative medicine, back in the dark ages in the 90s when I went to med school, early 90s.
If I needed a knee replacement and I had knee pain, like nagging knee pain that was preventing me from doing the sports that I wanted to, then I could come in, I could work with you, and within maybe a couple months, I would see either this is enough to mitigate the potential knee replacement, or I could still have it and perhaps I'll get better results and maintain or retain or even gain functionality after the surgery because I went in and had and combined the two.
Yeah, we have some people that have tears that and we try to treat them with the exosomes, and down the line they're feeling better, they're not suffering, they're able to do what they want to do, and they just live with the tear. It's like the spine. You can live with a disc herniation if it's not bothering you.
One other thing I want to ask you about in this realm is the role and your perspective on cortisone shots.
So cortisone has a role in the suppression of painful acute inflammation. Like you're a mess, you can't walk, your knee is swollen and red, and it's acute injury. There's a role there. It's the repeat overuse of those that actually accelerates the degeneration because it suppresses those cellular functions as a side effect. So it's got its role. Probably we're overusing it. And before I got into regenerative medicine, I recommended tons of cortisone shots in the spine, and they were helpful in the right setting. But they do reduce the cartilage function, particularly in cartilaginous joints. So in the spine, for like an epidural injection is different. That's not for the joint itself, but some of the facet joints and other things can be affected long-term if you keep doing those.
So if you have the ability, you have the choice, you have minimal pain, you can come work with you instead and get an exosome treatment done and see if that relieves it enough. Because to me, it seems like you're going to rob Peter to pay Paul by going and getting these done, because then you're going to be degenerating your cartilage and other things that you don't want. And you're going to facilitate the onset of more issues down the line. So if you can avoid that and take a regenerative approach first, granted that you're not in extreme pain, then that might work better long term.
Yeah, if you're not like going to the emergency room, like, oh, I twisted my knee, it's this big, it's red, I can't sleep. Okay, you're going to need a cortisone shot just to get things, under control. That's okay. There's a role for that. That's the acute suppression. But there are people who go into the orthopedics office every time, they get a cortisone shot every time. That's just to kind of keep things quiet. That's probably not a best long-term management. That's all we had for decades. So I understand why it was used. And now we also have these lubricating injections, right? People go in for the hyaluronic acid or the rooster comb injections, Synvisc, what have you, in the knee. Usually go for a series of 3, and typically they need to be repeated periodically. Those are okay. Those aren't necessarily anti-inflammatory. They provide some lubrication for the knee. They're not regenerating the knee in any way. But if you do the intraosseous exosomes to stimulate the chondrocytes and the cells there, then your body will make the hyaluronic acid and lubricate its own joint. So which is kind of a better root cause fix.
Great. Well, if people want to dig into this world of regenerative medicine Are there any researchers or teachers that you found most helpful in your own journey?
Yeah, there's an organization called the A4M, which stands for the American Academy of Anti-Aging Medicine. It's really where we flock, the doctors who do this kind of work. It's not just for clinicians, and they have resources online. I think it's a4m.com. They have great resources and webinars you can attend, and the best researchers and those who publish a lot and have the most experience in peptides and things are on there. And I learn a lot still. And I go to the meeting in December of every year because it's here in Las Vegas, so it's around the corner. That's a great resource. You know, if you want to dig in, if you have a certain ailment or problem and you want to see if stem cells or exosomes are good, could be used for that, you search PubMed. You can Google PubMed, comma, whatever problem you're having, whatever symptom you're having, comma, stem cells. You can put in exosomes, but most of the work comes from the stem cells because they've been around for 20, 30 years. Exosomes have only been really available here in the US for about 6-7 years. So, and exosomes, by the way, make sure if you get them somewhere, you're getting it from a reputable source. That they're, I prefer they not be powdered form where you have to put fluid in to reconstitute them, like some of the peptides, because although the exosomes may be okay, you lose some of the growth factors and proteins that come with. So I like the fresh frozen stuff.
Well, thanks for that. If I ever decide to try and procure my own exosomes, I will keep that in mind. Dr. Jeff, thank you so much for coming on. Are there any closing thoughts you want to leave listeners with today?
Keep moving, exercise a little bit every day, get your steps in. It's better to do fewer steps faster and harder uphill than it is to do more steps. So that's a hack. Intermittent fast or intermittent feed, as I like to call it. Be anti-inflammatory in almost everything you do, whether it's from mindfulness, restorative sleep, supplements, diet. And if all that doesn't work, come talk to us about exosomes.
Well, again, thank you for coming on. It's been a blast chatting about all things regenerative medicine, and I'm looking forward to staying in touch and following your work as you branch out and go deeper into the exosome and stem cell therapy rabbit holes, as well as some of the new frontiers that emerge down the line.
Absolutely. Thank you so much. I appreciate it. Thank you.
I hope that this has been helpful for you. If you enjoyed it, subscribe and hit the thumbs up. I love knowing who's in the 1% committed to reaching their full potential. Comment 1% below so that I know who you are. For all the resources and links, meet me on my website at mindbodypeak.com. I appreciate you and look forward to connecting with you. As a reminder, the information depicted in this video is for information purposes only. Please consult your primary healthcare professional before making any lifestyle changes.